this is a schedule that we will have. We will talk about the basic anatomy of spine and spinal cord. Nous allons parler de l'anatomie de base du rachis et de la moelle spinale, qui sera présentée par le docteur Mirza Posrich. Et ensuite, on verra la biomécanique, les principes généraux de la biomécanique, les principes également de la biomécanique relative aux implants. Et après cela, nous aurons une présentation sur la prise de décision et les diagnostics dans le traitement des pathologies du rachis. Suivi de cela, nous aurons une petite pause café. Ensuite, nous verrons tout ce qui est lésion de la colonne vertébrale du rachis donc, et de la moelle spinale. Donc, sans plus tarder, nous allons laisser place au docteur Posrich pour sa présentation sur l'anatomie du rachis et de la moelle spinale.
Dear colleagues, dear friends, dear participants of the course, thank you for coming. Thank you for the wonderful organization and the warm welcome. My name is Mirza Kovacic. I'm a neurosurgeon from Department of Neurosurgery in Marburg, Germany. Actually, I come from Bosnia-Herzegovina, where I was born and raised, and 10 years ago I've immigrated to Germany and work ever since in the German healthcare system. I'm a member of the WFNS Spine Committee since last year, and I'm very proud and honored to present several talks in this course. Unfortunately, not all members of the WFNS Spine Committee who wanted to be here are here with us, but we will try to manage and cope without them. So the first lecture is obviously on basic anatomy of the spine and spinal cord, which you need to know if you want to be one day a good or a solid spine surgeon. A good solid spine surgeon does not mean that you do all the complex and very complicated cases, but to do the cases which you need in your practice and to do it correctly and properly. So objectives are to understand the basic anatomy of the spinal column, the spine regions, numbering, junction areas, ligaments, and paravertebral muscles, to comprehend the specific anatomical details of the spine, differences between the vertebrae and spinal cord segments, numbering, location of existing and transversing nerve roots in the different regions of the spine, relations to the body cavities, and basics of spinal cord anatomy and vasculature. This is usually the knowledge which you get at the medical school, but in our opinion, residents in first, second, third year often lack this basic knowledge and basic understanding of the spine, and this is why we have decided to start with this lecture today. So we're going to talk about spine anatomy, anatomy of the spine or vertebral column, and about the anatomy of spinal cord. Segments and regions of the spine. So there are 7 cervical, 12 thoracic, and 5 lumbar vertebrae. Sacrum is consisted of 5 sacral vertebrae which are connected into one bone called sacrum, and coccyx has 4 vertebrae which are also connected to one bone. Neurosurgeons usually stop at S3, S4 level in coccyx, and that is usually then surgeries in these regions are performed by some other specialties. But for the cervical, thoracic, and lumbar spine, in the present day surgery, this has been something which we have taken over from orthopedic surgeons or still do that together with them. So to know this anatomy thoroughly is a must. There are variations on number of lumbar vertebrae. There is so-called sacralization or lumbalization. I'm going to talk about it a bit later. And all of these vertebrae, cervical, thoracic, and lumbar, have their specific anatomy, which you need to know, like from an anatomical book, when you one day want to operate on it. Surface landmarks of spine levels. This is from a very good book whom I would recommend everyone. This is a Greenberg, actually a basic book for neurosurgeons, which we use for preparing our boards. This is Greenberg Spine. And all of the most important info on spine, basic info on spine, you can get from that book. And this is just to get a small overview where the spine is compared to the other parts of the human body. C1 and 2 is the angle of mandible, C3, 4 is 1 centimeter above the thyroid cartilage. C4-5 is the level of the cartilage. 5-6 is cricothyroid membrane, 6 is cardiac tubercle, and 6-7 is cricoid cartilage. These are important radiological landmarks when you look at them, and they can also have a surgical relevance. Scapular line is T2-3, inferior scapular pole is T6 posteriorly. Vertebral numbering and variations, since we are totally dependent on radiology, on simple X-ray, on CT, or ideally on MRI, it is important to know the numbering of the vertebrae if you have a MRI of the spine, of thoracic spine, or a lumbar spine, or of total spine. Important is, if you have a pathology in thoracic spine, you have to try to insist with your radiologist to make a hollow spine MRI or total spine MRI, otherwise the counting can be difficult. And the first vertebra in the sagittal MRI or CT slides is actually not C1 but C2, because C1 you usually don't see. You see the anterior arch of the C1 like shown on the picture on the right side, but this whole block of the first vertebra is actually C2, so you start to count from C2 downwards. Vertebral numbering and variations, there is the so-called cervical rib, which then can make you on a normal X-ray to ask yourself, is that the first thoracic vertebra or is it the 7th cervical vertebra? Rudimentary 12 for thoracic rib can be absent or present. That can make things hard if you are trying to localize the level of the spine on the AP X-ray. There is a case of lumbalization of S1 when you have 6 lumbar vertebrae, and sacralization of L5 where you have 4 lumbar vertebrae. If you have this situation and you look at the sagittal X-ray of the spine and you think that this person might have 1 vertebra or 1 lumbar vertebra too many, then it's always wise to take an AP X-ray and then to count from the last vertebra, and then you will always know if it's 5 or 6. And counting from the 11th rib downwards. Parts of vertebra. You don't have to know actually in detail every part of the vertebra, of the single vertebra, and every relationship to the part of the body, but generally you should know that in the cervical vertebrae you have the foramen transversarium or transverse process. We have the foramen through which the vertebral artery goes, and if you drill too laterally during the surgery, then you can open up a vertebral artery, which does not happen in thoracic or in lumbar spine, and you always have to be aware of this anatomy. Also, the vertebrae in cervical spine have lateral masses, and lateral masses are places where we usually put screw in the cervical spine, so we don't tend to put it through the pedicle unless we have increased visualization, like navigation, but lateral mass screws you can put without even without X-ray if you know the anatomy. Thoracic spine and lumbar spines are are more similar to each other. What you have in the lumbar spine, when it comes to the bony structures, is a transverse process, which you see on the picture on the last under C. And the transverse process is, if you palpate it during the surgery, that's a very good starting point to drill the hole for the insertion of the pedicle screws. Especially if you don't have an intraoperative C-arm, you can do then anatomical screws of the lumbar spine only if you know the anatomy and if you have some kind of orientation and 3D understanding of the anatomy, where sawbone courses and cadaver courses can help you a lot. Facet joints of the spine, very important part of the spine pathology. There is a whole disease called facet joint disease, with pain which is axial and which is radiating usually to the hip or to the groin, and there are numbers and numbers of patients, especially in the developed world, who get surgeries for facet joint pain, and we still then have pain for facet joint, and it could have been revealed only with a simple blockade or with a simple infiltration. Facet joints connect the vertebrae on the lateral side, and they make the lateral and posterolateral border of the neuroforamen. And the hypertrophy of facet joints can lead to spinal canal stenosis, to neuroforaminal stenosis, and to neuroforaminal cysts, facet joint cysts. And you should always take a good look at the facet joints when you are trying to understand the MRI of the patient, CT of the patient, and his problems. Spinal ligaments. This is one axial MRI of the cervical spine, which shows the most important ligaments which you need to know for clinical work. Of course, anterior and posterior longitudinal ligament and ligamentum flavum are the three most important ligaments, or the three ligaments which you almost always encounter in your practice if you do spine surgery. But it is important to know that you can divide them into intra and intersegmental ligaments and ligaments of the craniocervical junction. Also, there is the so-called ligamentum nuchae, which is a conjoined name for supraspinous and intraspinous ligaments in the cervical spine. Paravertebral muscles. Most neurosurgeons don't know names of all of these muscles in the cervical, lumbar, and thoracic spine. We usually know the ventral cervical muscles, the omohyoideus, which we encounter when we do this ACDF, and the trapezius muscle, latissimus dorsi, if we do the posterior thoracolumbar surgery. It is important to know that they go in several layers, and that the muscle trauma is also one of the core mechanisms of the spinal instability. So in surgery, it is important to respect the muscle layers and to try to divide muscles from the bones in a way where the readaptation of these muscles is going to be possible. So not to destroy all the muscles, but just to do the subperiosteal layer preparation of them in the thoracolumbar spine and also in the cervical spine. This muscle trauma is one of the reasons why minimally invasive surgery developed. So surgery where you put percutaneous screws via very small incisions on the lateral side of the spine in order to minimize the muscle trauma. So, as for muscles, there are these external muscles which go along the vertebral column, but there are also very important psoas muscles which you don't see on the outside. They are deep on the lateral sides of the lumbar spine. Through the psoas muscles flows the lumbar plexus, the nerves L1 to L5, and these muscles are very important for two reasons. One reason is in the infection diseases of the spine. There is very often an abscess in the psoas muscle, which we very often do not see, for example, in spondylodiscitis of the lumbar spine. And be sure always to check if the patient if his infection parameters are not going down under antibiotics, if he doesn't need a punction of the psoas abscess. And the second important reason is that for lateral approaches to the spine, for lateral surgery, if you do a lateral approach, you have to know the anatomy of the transpsoas muscle and use the neuromonitoring for transpsoas approach in order not to cause more damage than good. In cervical spine, atlas and axis have their specific anatomy, which is different than any other vertebrae. This is something you need to know. The axis of the C2 and classifications. We are going to talk about it later, of the C2 fractures which revolve around the axis. Also the anatomy of the atlas, which has actually two arches, anterior and posterior, and two massa lateralis, and two transverse processes, and the transverse ligament which divides it from the dens, which is in the anterior part of the spinal canal in the cervical spine. And these are the only two vertebrae which you need to know, like I said, which you need to know in detail their surgical anatomy, because C1, C2 stabilization techniques and the whole anatomy of cranial cervical complex is something different than the subaxial cervical spine. In subaxial cervical spine, this is a term for vertebra C3 to C7. Like I said, they have foramen transversalium with the vertebral artery, which you need to take care of during surgery, and lateral masses. They don't have very thick pedicles, and these pedicles are not very suitable for pedicle screws, although you can do it either if you're very experienced or you have a very good navigation. In thoracic spine, lateral approaches to thoracic spine, i.e. the costotransversal joints, it's very important to know for simple surgeries in the thoracic spine, for example, for herniated disc, that you cannot do here a simple hemilaminectomy and try to stay as medial as you can, but you usually need to go through the costotransversal joint. And when you go through the costotransversal joint and resect it, you have to have in mind that the lungs and the pleura are very near to the place where you perform surgeries. And these are also some anatomical nuances which you have to have in mind. Also, aorta goes along the anterior faces of the thoracic vertebrae, and it can be easily damaged in this kind of surgery. The lumbar spine, this is probably the part of the spine with which most surgeons or more general spine surgeons experience with the biggest vertebrae, the thickest pedicles. Actually, very nice surgeries when it comes to stabilization, but also the, so to say, epidemiologically seen, the reason number one why people go to see a spine surgeon. Cervical spinal canal, the lumbar spinal canal stenosis and lumbar herniated discs. And what you need to know is that spinal canal stenosis and herniated disc are two different diseases. They can come together, but they actually have different pathophysiologies, and they have also different treatment. Whereas in herniated disc, it's enough to take or remove the disc out. In a complex spinal canal stenosis, you usually need either to stabilize and put the ligaments and the hypertrophied facet joints out, or you can do a simple decompression without putting screws. But in order to understand, comprehend what does the patient have, what are his problems, you need to know which nerves go where, for which neuroforamen, and how are the anatomical structures aligned. Craniocervical junction, this is like I said previously, a specific part of the spine, which anatomy you need to know more into detail than some other parts of the spine. Under craniocervical complex, we understand not only C1, C2 complex, but also clinoid and also the occiput. You need to know the cruciate ligaments and anterior and posterior tectorial membrane in order to understand the pathology which we are going to talk about later, craniocervical stabilization techniques or atlantoaxial dislocation. The modern day spine surgery revolves all around imaging with CTs and with MRIs, and we have here an example of CT where you have a parasagittal view of the craniovertebral junction, where we all see marked occipital condyles, facets of C2 ganglion, which is marked here with a thin arrow, hypoglossal canal, lateral masses, vertebral arteries, as well as vertebral artery sulcus. Cervicothoracic and thoracolumbar junction. Ventral surgeries in cervicothoracic and thoracolumbar junctions exist, but they are maybe 1 to 2% of the whole spine surgery. For example, the photo which you see on the left side, where you go in the near the big vessels which go out from the heart, where you do a ventral approach. Some people do that, but it's not very common. But for surgeries on cervicothoracic and thoracolumbar junction, from biomechanical and from stability point of view, you need to know that you usually don't stop surgery at the last vertebra of the junction. So if you have a pathology at T1 and need to stabilize, you always have to look if there is an instability of C6, C7, T1, T2, and the same goes for the thoracolumbar junction, because thoracic spine is one big breast gasket with the ribs, and has a totally different biomechanics, which we are going to hear about, than the cervical spine and lumbar spine alone. You have to know the diaphragm, and that it's a muscle which you usually see via lateral approaches to the spine if you need to do a complex reconstruction of a metastatic disease in T12 or in L1. Lumbar-sacral junction is also important for instability of the lumbar-sacral junction, and for stabilization surgeries at this level. You can stabilize practically S1, S2 surgeries in this area. You always have to know that if you do herniated disc, a simple disc L5, S1, when you position the patient prone and when you are going into that window, you have to know that the sacrum has, in German it's called the so-called Hochstand or Hochstanding. It is positioned like this compared to the lumbar spine, and the dura makes a slope. So if you do COURSE drills or diamond drills, you always need to have that anatomical slope in mind in order not to land in the dura and produce a fatal nerve injury or a fatal dural injury. The ventral approaches to the lumbar sacral junction, L5, S1. This is one of the regions of the spine where you want to do, or we want to put a very big cage. You cannot access it via the lateral approach. You can only access it via the so-called OLIF or ALIF approach. And ALIF approach is so dissectomy of L5, S1 disc and implantation of the cage. It's always, if you need a really big cage, then you do it ventrally together with the colleagues from the general surgery. And then you need to know that aorta and iliac arteries are dividing at L4, so that surgery is at L4 not possible, but there are also variations which you have to have in mind before performing ventral surgeries in this area. It's luckily something that we don't do that often, something that we always do with general surgeons together. So this is crucial for basic anatomy of the spine, relationship of cervical and lumbar nerve roots to intervertebral discs. So in the cervical spine, you first have the vertebra, and then you have the nerve root. And in the lumbar spine, is the other way around. So if between occiput and between C1, you have a C1 nerve root, and between C1 and C2, you have a C2 nerve root, and the lumbar spine is different. So if you have a intraforaminal herniated disc between L5 and S1, this intraforaminal disc is going to compress the L5 nerve root and not the S1. Because in the neuroforamen between L5 and S1, you will have the L5 nerve root, which goes out of the spine and goes then in the lumbar plexus and in the leg. Spine, for the anatomy of spinal cords and nerve roots, every nerve root has its ventral and dorsal root and spinal ganglion, and all nerve roots form in the spinal canal conus medullaris. This is the tapered end of the spinal cord, forming a long filament called filum terminale, which will become the coccygeal ligament, which anchors the spinal cords in place. Conus is around at the level of T12, and cauda equina is a collection of nerve roots at the inferior end of the vertebral column, and the lumbar and sacral nerve roots must descend before exiting the proper intervertebral foramen or sacral foramen. So these are the anatomical photos of the cervical spine and of the lumbar spine. From the posterior side, you will see the dentate ligament structure, which goes between anterior and lateral side of the spinal cord, which you can resect during surgery in order to move and invert the spinal cord if you need it. Here you have marks of the conus and cauda equina, and spinal cord. In order to understand spinal cord tracts and dermatomes and sensory nerves, you first need to know this microscopical anatomy of the cord. So anatomy of the spinal cord is something else than the anatomy of the spinal column. Spinal cord has gray and white matter. Gray matter is in the form of the butterfly on the cross section. It has an anterior median fissure and posterior median sulcus or central canal. These structures are actually to be seen on the anatomical preparations. And there are spinal cord pathways, which you also need to know that in the posterior column you have the so-called dorsolateral fasciculus and fasciculus proprius. They are bidirectional tracts. The anterior horn contains the descendant motor tracts, and the anterolateral horn, the anterolateral part of the spinal cord, has extrapyramidal motor control tracts like tractus lumbrospinalis, vestibulospinal tract, and lateral corticospinal tract. Dermatomes are areas of the body where sensation is subserved by a single nerve root, and peripheral nerves generally receive contributions from more than one dermatome. That means that a lesion in peripheral nerve and lesion in nerve root may sometimes be distinguished in part by the pattern of sensory loss. And a classic example would be splitting of the ring finger and median nerve or ulnar nerve lesions, which does not occur in C8 nerve root injuries. Spinal cord vasculature, so the anterior spinal artery is formed from the junction of two branches, each from one of the vertebral arteries, and major contributions of blood supply from 6 to 8 radicular arteries at the following levels, the so-called radiculomedullary arteries. The levels listed are fairly consistent, but the side varies. So C3 arises from the vertebral artery, C6 and C8, 10% of population lack an anterior radicular artery in lower cervical spine. C6 usually arises from deep cervical arteries, C8 from costocervical trunk. And the most important vessel is arteria vadateria, or arteria radicularis anterior magna. Is the main arterial supply for the spinal cord from T8 to conus. It is located on the left, mostly 80% of cases, and situated between T9 and L2 in 85% of the cases, remaining 15% T5 and T8. Relationship of spinal column to body cavities is important for anatomical understanding and for surgical approaches to the spine. Nowadays you have a lot of lateral approaches to the spine, to cervical, but more to thoracolumbar spine and the thoracolumbar junctions. There are anterior approaches like in ALIF and OLIF surgeries, and there are also some anterior approaches to the cervicothoracic junction, although rarely. There is also a transoral approach to the cervical spine, and in order to understand these approaches and what can possibly, what can go wrong and which complications you can incur and what to follow, you need to know at which level does the spine cord, which kind of relationship does the spine, the vertebral column, has to aorta and to neighboring neurovascular structures. So the take-home messages would be to learn differences in numbering of vertebrae and spinal cord segments, dermatomes and nerve roots. I think the most important thing is to learn the differences between cervical and lumbar roots, numbering of the roots compared to numbering of the vertebrae. To learn the specific anatomy of craniocervical junction and C1 and C2 vertebrae, shape of vertebrae and their anatomical relations, to know the joints and ligaments and their main biomechanical functions, and to understand the anatomy of the spinal cord and its vascular supply. So thank you very much.